Well, thank you all so much for joining today, whether you're here with us live or are watching this afterwards. My name is Emily Kile, and I am an attorney in Scottsdale. And I have been practicing for almost 30 years. Since 1993 is when I got my license. And I'm thrilled that we have Maribeth Gallagher with us here today from Hospice of the Valley. I don't even know how many years back we go, but I am always inspired by her presentations and by her. And I always learn so much, even after doing this for this long period of time. I still feel like, oh, I didn't know that was a service, or I didn't realize that's something we should keep our eyes open for, or this is a great way to deal with whatever that issue might be. So I'll let you introduce yourself more if you'd like to, but I really am thrilled to have you here. Thank you so much.
Oh, thank you so much, Emily. I appreciate everything that you do. Well, hi, everybody. So I'm the director of the Dementia Program here at Hospice of the Valley. I'm in my 19th year here at Hospice of the Valley. All I do all the time is I specialize in dementia. My background is that I'm a nurse practitioner, board certified in psychiatry. I also have a doctoral degree in nursing, but probably most importantly, I was the family member of someone with dementia. From pre-diagnosis, seeing some odd behavior, all the way until finally she died on hospice service. The experience for me was challenging, to say the least, but also ultimately transformative. And because of that, I drastically changed careers. I had been a professional singer for 30 years internationally, went back to school and decided to choose the nursing avenue of specializing in dementia to see if there were any ways that I could help improve and contribute to the care of people living with dementia and their caregivers, because this can be a very tough journey. So what I'm going to be talking to you today about is a program that's not hospice, but we have here at Hospice of the Valley. It's called Supportive Care for Dementia Program, and it is for any stage of any type of dementia. So let me dive into it. Let me give a little bit of background here for Arizona, first of all. Let's see. Okay, so I just want to share some 2023 statistics for Alzheimer's disease. So we know that there's easily over 6.7 million people living with Alzheimer's disease, and we know that the greatest risk factor for Alzheimer's disease is age. So when we get to 65 and older, which every day at least 10,000 baby boomers are turning 65, well, we know that 1 in 9 people age 65 and older have some form of dementia. Another 22% have what's called mild cognitive impairment. So this is pre-dementia. By the time we get to 85 and older, which is a really fast-growing segment of our population these days, about a third of people have some stage of some type of dementia. Now, dementia is not a normal part of aging, right? Very important to know. But you can see how common this is. And then you can read the rest of the bullet points if you want, but 2/3 of them are women. Older Black Americans are about twice as likely to have dementia. Older Hispanics and Native Americans about 1.5 times as likely. So if age is the greatest risk factor for having Alzheimer's type of dementia, there's many types of dementia, right? If age is the greatest risk factor, and we're in the state of Arizona where there's a lot of people who are aging, you can see that our state's one of the highest growth rates for dementia. Where are we with the state of the science? Well, I'm sure when you've watched the news or you're exposed to any social media, you're hearing about these new medications that are coming out. Now, these medications, maybe they don't have a robust impact on dementia, but finally it's a message of hope, because it's letting us know that what is being targeted seems to be an area that really will have ultimately an impact on perhaps disease modification, at least. We still don't have a cure for Alzheimer's disease or any of the forms of dementia. We're getting a lot better idea about prevention. Meaning that if you have the genes that predispose you, there's still the lifestyle choices, the environmental exposure, etc., that influences this. And even if we can't prevent dementia, might we at best delay the onset of it, So what I always like to say is, look, I'm working hard at delaying the onset of it, because if I delay it long enough, maybe I'll be dead, or maybe I'll be near death by the time it starts to come on, you know? But we know cure, ideas about prevention. We don't have any medications to stop the progression of the disease. We're starting to see in these latest ones that you're hearing about a potential to get rid of the beta amyloid plaques that may help improve a person. In spite of where we are scientifically today, there's a saying that says, cure sometimes, treat often, comfort always. When people with dementia who can still articulate are asked, what is most important to you in the context of knowing that you have a progressive neurodegenerative terminal condition? Almost everybody says, keep me safe, keep me comfortable, focus on quality of life. When it's my time, it's my time. Do not prolong my dying. So in the theme of all of the research, people want to be safe and they want to be comfortable. And when I talk about comfort, I'm talking about comfort in body, mind, and spirit. So in the absence of a cure for any Alzheimer's disease and any form of dementia, there's always much that can be done to focus on quality of life. We know, and I bet you do too, that Alzheimer's disease and other forms of dementia have a devastating impact not only on the person living with the condition, but also on the caregivers, or as sometimes we like to use the phrase, care partner. Care partner has this, it upholds the dignity of the person with dementia, saying that you and I are partnering. You know, it's not a one-directional, I'm giving you care. We're in it together in a collaborative approach. So you'll hear me intersperse those terms. Interestingly enough, where we are is that the bulk of all the care that a person with dementia receives is given by family and friends. And guess what the research says? Caring for an individual with dementia creates or aggravates health problems, doesn't it? In body, mind, and spirit. People, when they're diagnosed with Alzheimer's disease, by the time they receive a formal diagnosis, generally the stats would say it's maybe 6 to 8 years, 7 to 9 years, whatever, until they die, right? So they're moving through this progression of the condition. And this slide is just really showing that over time, the person's ability to independently care for themselves is going to decline. And what that means is, you as the caregiver are going to have to step in more and more in order to keep the person safe and to help them meet all of the needs that they have. When we look at the literature also, it says we are not doing a very good job of helping people living with dementia and their caregivers. And here's a couple of reasons why. PLWD is just shorthand for people living with dementia, person living with dementia. We know that people living with dementia have complex care needs, and there's a long period of disability or when they need the help of others. Why complex care needs? Well, we all know that this generally is happening to older adults, and as we get older, we tend to have these kind of chronic conditions that emerge. Also, if you're a dementia caregiver, you know that changes are unpredictable. Sometimes you have these crises and then you get them managed, you go, and you're moving along, and then all of a sudden, boop, another challenge happens. We know that family and friends are the individuals giving almost all of the care for people with dementia, and yet, how many of us have had training on how to be a caregiver, specifically a dementia caregiver? How much training have we had? And the answer is zip, you know? So, then we know that, let's say you're your advocate for your person. So you are talking to the medical provider and you're making decisions. Well, a decision for somebody in the early stage of dementia could be quite different than the same decision, like let's say to repair a significant fracture. The decision when the person's in the advanced stage, it can be very different. And this requires really skillful ongoing conversations in order to make sure that the goals of care align with what this individual would want for themselves. We see a lot of gaps in healthcare services. I bet you're experiencing this too. The cardiologist doesn't know what the gastroenterologist, what the pulmonologist, what the primary care provider. People don't necessarily know what the other one is saying, and sometimes they're saying things that are opposing one another. We also know that primarily people living with dementia, if they are receiving care, are probably getting it from their primary care provider, their PCP, not a center of dementia excellence. And yet PCPs are saying in the literature that they're woefully unprepared in order to do dementia management. They want to do their best, but this isn't something that they learned as well. All right, so putting everything I just said together, that sets the stage for raising the critical questions of what type of supports have been proven to help optimize well-being, not only for the person living with dementia, but for their care partners. What interventions are going to reduce unnecessary stress and strain as the condition continues to progress along with time? Well, a review of the international research says here's what people need. A, they need informational support, meaning they need dementia education. What is it? How does it affect the brain? Why are the people behaving in this way? How do I communicate with them when the traditional forms of communication are failing? Also, how many times, if you have been a dementia care partner, when you're in, let's see, seeing a doctor, nurse practitioner, does somebody stop after they focus on the person with dementia and then look at you and really give you a moment just to say, so how are you doing? And to listen to how you're doing to optimize your own well-being. So emotional support for the dementia caregivers. And then instrumental support, which is where Emily comes in so well, of legal, financial assistance. How do we know about in-home help? And how do we know how to discern between the people that aren't very good and the people who really know that they can make a positive difference in your life? And then what about respite opportunities? Have you ever heard about adult day centers, which are a hoot? And who are the other key support people? You know, being in Arizona, my common experience is I see a husband and a wife. They're probably from the north or the northeast or something. And they come out here and all of their support folks are living in another state. Well, COVID was the greatest teacher for letting us know you not only have to have a plan A, meaning that your spouse is taking care of you, but you better have a plan B and C, because COVID ripped the caregiver out of the situation and there was no one to take care of the person living with dementia, nor did anybody know the depth of the deficits, etc., that the person had. So who are these key support people? So this is just touching upon what we've found internationally to be the most effective support. Based on that information, in 2013, we created a program that tried to fill this gap, and it's called Supportive Care for Dementia Program. The goal, ultimately, big time, is to improve health outcomes and quality of life for both the person living with dementia and the care partners. The emphasis, based on the literature, was that to provide the education and the psychosocial support in order to help people navigate all of the dementia-related challenges that were going to arise. There's a tiny, tiny bit of medical oversight, meaning we don't become your medical provider. But how can we possibly take care of an individual if we don't know about their medical conditions? That's not holistic care. To provide excellent care, you have to know about the whole person. So we just gather that information to help influence how we customize the support for you. Bottom line focus, living well with dementia, whole person comfort. So what it is it's a free program. And essentially, initially we go into the person's home. Why? Because when we see the person in the context of their environment, we have so much more information than a clinician who, when you go into the clinician's office, will ever have. We can see safety implications, we can see potential problems, potential things that we could use for success. But a whole lot of this information can be exchanged over the phone. But first and foremost, we want to go into the person's home. Also, if you ever know a person with dementia who goes into a doctor's office, for 15 minutes, the person with dementia can put on like showtime and really show up with their best presentation. And the physician may look at you and go, I don't really see a problem here. And you're like, wait a minute, this is not the way that it usually is. You know that in 15 minutes, that person's social facade, as we call it, is probably going to collapse. So when we see the person in the context of their environment for a longer period of time, we get more information. One of the most important parts of this program If you've been a dementia caregiver, you know that hardly anything goes wrong Monday through Friday, 9 to 5, when you can call the primary care office. What happens is, in the middle of the night or on the weekend or on a holiday, you call the number and you get, if this is an emergency, please hang up and call 911. Otherwise, please call us back on Monday at 9 a.m. Thank you. Now, what are you supposed to do? So you know what a lot of caregivers wind up doing? Calling 911 because they're scared. They're so afraid of not making the right decision, and they need support. So they call 911. First responders come in, God bless them, but they're moving at a very rapid pace, which is a recipe for disaster for a person with dementia who's processing things more slowly, who's wondering who the heck these strangers are in my house. And then sometimes what happens is they get scooped and brought to the emergency department, which is one of the worst places if it's preventable for a person with dementia. So instead, we created this 24/7 phone line, which always has a human being on the other end. Always, never a recording. And it's a nurse who understands dementia, who is going to listen to you and discern, is this indeed a danger to self, danger to others, a reason to call 911. But there are so many reasons. I would say easily 80% of the 911 calls are preventable. When we know better, we do better, Dr. Maya Angelou says, right? So the nurse on the other end will listen and then maybe help figure out what's going on. We can also pull up in our electronic health system what meds the person's on, what kind of conditions they have. Again, because we have that little bit of medical information, it helps us see that bigger picture. And then the nurses sometimes, if it's a behavior, they'll say, hey, why don't you put the phone down and try this instead of what you're doing? And then I'll wait. Or the nurse may say, try this, and the person will go, oh, okay, that sounds good, I'll try that. And the nurse might say, can I call you back in 2 hours to check in on you? And we just do that bridge to help you get through those dark hours, and then oftentimes you can call the PCP in the morning, or we can call, or it just helps people feel like they really can do this. And just that alone helps prevent institutionalization of people with dementia, because it allows the caregivers to feel that somebody really does have their back, And how much is this program? It's free. So again, it's support for any level of any type of dementia, including those folks who don't have a formal diagnosis. Why is this important? Do you know that 50% of people who have dementia will never have a formal diagnosis? But they're out there, We even on our program try our best to help people who are living alone. Now, this is pretty darn challenging because some people don't want any help, but we just try our best to work with you and to get some help whenever possible. So the first 2 visits are usually in the home, and then the other visits are usually by phone. Usually it's about 5 to 6 months the person's on, but if they have greater needs, of course, we're not going to have them get off. And then usually people have the resources, because we provided them with so much education and resources, they can do this. But if, as they're navigating, as the condition progresses, they need more help, they can call back and get back on the program if needed. So what would be examples of the people that go out? So you're assigned a dementia educator. That's what we call them, DEs. So the educator, when they go to visit, they're going to do cognitive assessment. Maybe you've heard of something called the mini mental state exam, or the MOCA, the Montreal Cognitive Assessment. And essentially we want to see right here, right now, how's the brain doing? Where is the brain not working the way it once did? And where are the residual abilities that the brain still has? Because we want to know the deficit so that we can keep the person safe and anticipate what they need now that that part of the brain isn't working. In addition to that, though, we want to identify what the brain still can do, because we want to celebrate that and use it to its fullest extent, knowing that someday probably that too will decline. We're going to assess their functional level, right? How are they moving about the house, and is it safe? Again, safety in general living conditions. We always think about these Arizona homes with those sunken living rooms. Those are traps once people's visual, spatial, and attention starts to diminish. Also, let's make sure we know who the medical power of attorney is, who the mental health power of attorney is. We've got to get this stuff started. And, let's talk about like a human rights issue. People with dementia have rights, and while they still have the ability to identify who is going to speak to them, for them, when they can no longer speak for themselves, this is really important. We want to honor and get as much information from this person as is possible and document it so that we really can uphold this, so that they can live the life that they want. We're going to discuss goals of care. In other words, what matters most to you now and as you look down the road. We're going to complete those advanced directives, right? And then we're just going to educate. While we're doing advanced directives, we're also going to provide you with realistic outcomes associated with advanced directives. Okay, what does that mean? Okay, when you watch television and people have a cardiac arrest and they're resuscitated, what happens is 1 and 2 and 3 and 4, and all of a sudden the hands are off and the person's up and they're looking around, and that's generally not how it plays out. Your ribs are cracked, especially if you're an older person and an older person with dementia. You're going to be intubated, right? You're going to have a tube for breathing. You're probably going to be in an intensive care. And so some of the stats are that if a person has advanced dementia, and their heart stops and they're resuscitated, there is hardly any one of those, no matter that they get resuscitated, any of them that will be revived. And that rare individual who is revived will more than likely die within 24 hours. But now they're probably going to die intubated, restrained in an intensive care unit. That's okay if that's what the person wants. But again, let me bring you back to when I first started talking. That is not what most people want. Most people want to die at home. Most people want the focus to be comfort, and they want to be surrounded by their loved ones. Advanced directives is the most powerful single factor that will determine the difference. Also, we want to help you prevent any 911 calls and emergency room visits, because it's just stressful for everybody. And we want to make sure that we help connect you to the resources that are available in the community. I can't say to an 85-year-old woman who's caring for her husband with advanced dementia, listen, in your spare time, why don't you get on the internet and look up what resources are available, and then discern the difference between the ones that are legit and the ones that are just trying to sell you snake oil. That would be unrealistic, wouldn't it? So we are going to link you up with the resources. We're going to do that for you. So again, what the dementia educator is going to do is talk about disease progression. What does Alzheimer's or Lewy body or frontotemporal? This is the way the person looks now. What can we expect in the following months, in the year? What are the complications that commonly arise? What does it look like when a person has a urinary tract infection when they have dementia? Sometimes it shows up that they're hallucinating first, or they're falling, or they're sleeping for 24 hours before you ever realize that they have a urinary tract infection. How come people with dementia are known for having these behavioral expressions, right? Sundowning, as some people call it. Can I prevent or at least minimize these behaviors in the afternoon and evening? What about sleep issues? Because since the brain governs when the body wakes and sleeps, and this is a brain disease, we see all sorts of alterations in sleep issues. And if my person that I'm caring for has sleep issues, guess who else is going to have sleep issues? Me. Things like delirium. Pain is terribly underrecognized in people with dementia. This is low-hanging fruit. We want our person to be comfortable. So does the person want to be comfortable? How do we communicate with a person when their memory doesn't work and when they have difficulty understanding what's being said to them and articulating their own thoughts and feelings? There's certainly ways of communicating effectively. How do I prepare for the future? Okay, that's just some of the stuff for the person with dementia. Now, what about you, the caregiver, and self-care issues? Well, we do something called the Zarit Burden Interview, which assesses the strain on the caregiver and provide interventions in order to help you with that. Also, we teach you about something called ambiguous loss. Ambiguous loss is your person's here physically in front of you, but they're not here in the way that they once were, right? So they're here, but they're not here. And that dichotomy in so many ways of being a dementia caregiver is crazy making material for our emotional state. And you don't get a lot of empathy from others if they have not lived it. And you try to explain it to people, but they don't get it. So ambiguous loss, giving a name to it and looking at the research to say, how do we help you navigate through the grief that is so common that you're experiencing on a daily basis? Let's link you up with support groups. If you can't get out of the house, we've got virtual support groups as well. And then we even teach mindfulness meditation techniques of how to trigger what's called the parasympathetic nervous system. So you know about the sympathetic, fight, flight, and freeze. How do we shift you over into what's called tend and befriend, rest and digest, so that your body's not so stressed out. Also, most people want to take care of their person with dementia as long as they possibly can. And many of us made the promise, we'll never move you out of your home. But indeed, sometimes that is inevitable in the best of loving caregiver situations. So how can we possibly delay placement through things like adult day centers and other opportunities for respite in home care? And then how can we help you maybe choose the right place? When we institute, because what I'm trying to do is to share the scientific evidence with you, when we institute things like this, what we see as related to people living with dementia and their care partners is we see an increase of the advanced directives, more well-informed treatment plans, a better understanding of dementia skills so that you really can do this, you know what you're doing. We see an expertise that's evolving in your ability to read the nonverbal in the person and anticipate what they need to make them happy and focus on quality of life, less medications, more use of supportive resources, and then enhancing quality of life for the both of you. We see reduced emergency department visits and hospitalizations, reduced amount of medications, polypharmacy. As we get older, we tend to be on more medications, and they're all given for really good reasons, but when we're older, we don't metabolize them as well. And so it creates this chemical soup that sometimes works against us instead of for us. We see a decrease in distressing symptoms, behaviors, less depression, less caregiver strain and stress, and again, less transfers into long-term care placement. So these are all really positive things. So with our supportive care for dementia program, it's been acknowledged at a federal level and also published in the professional journal, saying that we've been able to decrease caregiver stress and decrease the behavioral expressions of distress in people with dementia. Let's see, what time is it? I was just going to very quickly kind of breathe life into this by saying, so for instance, let me give you some of our earlier clients, Richard and Barbara. They're both in their 80s. They were married for 59 years when we met them. And in his 70s, late 70s, Richard was diagnosed with Alzheimer's disease. So over time, it was getting worse, and Barbara promised that she would never, ever move Richard out of the home. She was going to take care of him forever. Now, Richard was a big guy. He was about 240 pounds. Barbara, on the other hand, was this petite little thing. But over time, Richard started to show increasing episodes of distressed behaviors. Sometimes he would threaten his wife and maybe grab her by the arm. And this wasn't Richard, right? But he was having difficulty understanding, interpreting his environment, and controlling his emotions. His sleep patterns where he was up and down all night. And Barbara, again, in her 80s, was worn out. Sometimes he would leave home without her noticing, and Barbara would just be so scared because he was lost out on the streets. Barbara was one of these Arizona families that didn't have any local family. They were on the East Coast. She didn't want in-home help. She didn't want strangers in her house, right? And she refused to place Richard in a facility. They had a really excellent geriatrician, Dr. J. He had a really busy practice, and as best he could, every time Barbara called in, for tips and please help me with Richard, Dr. J did the best he could, but A, he had a really busy practice, and B, he didn't have that much dementia experience. Again, physicians haven't been trained in dementia management for the most part. So they heard about the supportive care for dementia program, and their dementia educator is the woman in this picture, Amy. So Amy went out and visited them in their private home. So initially, she assessed the living environment for safety, throw regs, things that he could trip over. If Richard became agitated in the kitchen, and on the kitchen was that those knives, that are in the blocks, It might be a visual cue to pull it out for him to protect himself. So she assessed the living environment and made tips. She also did a cognitive assessment on Richard to see, wow, how far has his disease progressed? Where is his brain not working? Where is it working? So that Amy could explain this to Barbara so that she could really understand what was going on and why Richard was doing what he was doing. She also asked to clarify what were the goals of care. If Richard could see himself now, how would he advise Barbara on what is best for the both of them? Also, although we have an agenda of we know, based on the research, what is best for these couples, we keep that in our back pocket. And when we meet the couple, we say, what is your most pressing issue from your perspective? And that's where we'll start, because our job is to earn the trust of the people that we serve. Amy also noticed that Richard had a very unsteady gait, and that one of the reasons he was losing weight was because he couldn't do meals anymore. He needed finger foods and food lying around so he'd have visual cues to pick it up and eat it. Over time, more and more challenges arose, and Barbara and Amy would come together and brainstorm and then bring it back to our meetings, so that everything that they needed to navigate along the way, we all put our heads together. And we also customized that Richard, he was bored out of his mind, which a lot of people with dementia are. So how do we provide activities during the day that's going to bring him some joy, so that also Barbara could have some time to herself, and then also things that they could do together. I mean, they're committed 59 years. Also, what we did was, over time, we worked with Dr. J, as per his request, to just provide tips on, this medication may be good. This medication maybe isn't helping. And so we worked in a collaborative way. Dr. J stayed the direct doctor, but just we were able to provide some dementia expertise for him. We encouraged placement at a couple of different points, honestly, because it just seemed like I was afraid it was going to kill Barbara, but she kept refusing. Over time, though, she finally allowed us to provide some respite care for her, where she could take care of herself. At holiday time, Barbara's family did visit from the East Coast, and so Amy went out again in order to provide education on, this is how Dad is now. This is how you can relate to him. This is how you can trigger upset. So we really brought in that whole system, and this is how you can help Mom as well. Ultimately, as time went by, Richard finally qualified for hospice because he was at end of life. And he died a very peaceful death with Barbara at his side, with all of his comfort managed. And Barbara was incredibly grateful, saying that she never would have been able to manage it without our help. And Dr. J said, I need eyes in the home and feet on the ground to help assess the family, and then to get back with me. I can do a better job if I have collaborators. These families are desperate for some sort of coherent program that can give them an idea of what to expect, what they can do now and in the future, and to begin to plan for that natural progression. So I just want to kind of breathe life into the program. So that's our supportive care for dementia program. I also want to let you know, because we were talking about support groups, it's really difficult for people with dementia to get out of the house and to attend a support group. So I host one that's generally I'm there, except for rare occasions, on Tuesday morning on Zoom, 10 to 11, and it's very, very warm. Everybody will wholeheartedly welcome you to join, even if you're kind of nervous and shy and an introvert. And we start off with about 5 to 10 minutes of a mindfulness practice that I guide you through in order to settle down everybody's nervous system so that we can get clear and then really relate to one another. And you can bring any of your pressing needs to the group, and we brainstorm it so that hopefully you walk away enriched. Nicole, one of our best social workers, has a group at 12 o'clock on Wednesdays. Also, just so that you know, when dementia caregivers, when their person with dementia dies and they go to a bereavement support group, often they feel estranged because a person who, let's say, dies suddenly of a heart attack, their loved ones are left with this shock and this, oh my God, I can't believe this never happened. And of course they miss the person. A person with dementia, because of that ambiguous loss, they really miss their person. They really wish their person was here. But part of them, if they are to be honest, is kind of glad that the dementia journey is over because they didn't know if they would last another day. They can't say that to people who haven't lived the dementia journey. So we have a special bereavement group virtually just for dementia caregivers when their loved one dies. Also, when I talk about dementia education, there's so much to learn about dementia, really. And so on Thursday mornings, we have what's called the Know Better, Do Better class, and it's free. And you come on our dementia campus, and we cover all sorts of education and do questions and answers. Then for people who can't attend that, what we do, oh, and then we have CNAs here to sit with your person if we get advance notice, right? If you're coming here with your person with dementia. And then at noon, we switch and do an edited version of that education online on Zoom. It's called Dementia Bites. So I do it for 30 minutes instead of like an hour and 15 minutes. And then I provide 15-minute Q&A for any dementia-related issues. Just so that you know, if you're in town and you have a person living with dementia, on Monday mornings we have the Memory Cafe. It's free. Again, it's at our campus. You and your person with dementia can come. There's arts, there's all sorts of fun. And then once your person with dementia feels settled with the other people with dementia and they'll be entertained or engaged in any number of ways, then you can go off and be with other dementia caregivers and talk about whatever is on your mind. Anyway, there's many programs that we have here at Hospice of the Valley. And if you want to learn more about it, dementiacampus.org would be your way, or dementiacampus@hov.org. I never want to ever speak about dementia without bringing the voices of people living with dementia into whatever it is I'm talking about, right? Nothing about us without us. They actually did a study where they asked people living with dementia in the earlier stage, as you look down the road, knowing the condition that you have, what is most important to you? And this is what they said. It was a qualitative study. They said, keep me comfortable, recognize, evaluate, and treat pain and other symptoms. So here we go again. Comfort, comfort, comfort. Uphold my dignity. Facilitate self-determination and informed decision-making. Again, let me go back to the advanced directives. Maybe a person said they wanted to be resuscitated, but if resuscitation in an early stage as compared to the advanced stage, when we know that more than likely nobody's going to make it, they're going to have cracked ribs. If they do make it, they're going to be intubated and restrained and probably die in the ICU. That's helping a person make informed decisions. Provide staff skilled in palliative, which simply means comfort, dementia care. And interestingly enough, of all the participants in the study, not one of them wished for heroic methods or resuscitation. Again, this theme that I've been hearing about for literally 20 years now, keep me safe, keep me comfortable. When it's my time, it's my time. So the theme here is scientifically, we don't have a cure, and I really look forward to that, and truly proven preventative measures. But until then, hopefully you're getting that sense of there's always more that we can do. We can focus on comfort in body, mind, and spirit and optimize well-being for everybody involved. So that's the end of my PowerPoint.
So when you say that there's no cost, and if others have questions, just type them in the chat or the Q&A. Do they have to have Medicare? Is it billed through insurance?
It's not billed. No bills.
No bills at all. Okay. And they don't have to prove financial need
Nope.
or income level or any of that.
No. Great questions. Thank you.
Because I think people think free,
Right.
or sort of free.
Yeah, so no, great questions. And that's how I am as well when I ask about things like that. Here's the deal. So because the federal government is so excited because they're looking for models to scale at a federal level because every place needs these. So we do have some grant money, but in addition to that, Hospice of the Valley Board of Directors has decided this is so important to provide for our community that it's giving back.
Wonderful.
We're a nonprofit. So here's where our profits go,
That's great. That's wonderful. And they don't have to be on hospice services yet.
No, and really, I want to say that a couple of times because people don't hear that, Emily. any stage of dementia. And remember, 50% of people don't have a formal diagnosis, but there's something, yeah.
Okay. Well, wonderful. Like I said, every time I hear you, I'm inspired and I learn new information. I tell myself every day, today is the day that I'm going to do some mindfulness. And then I get into traffic and I think, nope, mindfulness will have to wait. So again, I am inspired to set aside 5 minutes each day and slow down and get my
Breathe.
system relaxed so that I can face what the challenges are. So I don't see any questions. I'm thrilled for the participants and those who listen later. Maribeth, you're fantastic and lovely. And so thank you so much for your time today and all the work that you do for families to help them feel more comfortable and get their needs met. So thank you very much.
Thank you. Thank you for everything that you do. I'm so glad you do what you do.
Wonderful.
Thank you,
Well, enjoy.
Maribeth. Thank you, Emily.
You're
Absolutely.
welcome,
Thank you,
Eric.
Eric.
Oh, very nice.
We got some thank yous.
Yeah.
Wonderful. Well, thank you. Enjoy the rest of your week. And we'll see everybody hopefully next month for our next webinar. Thank you.
All right. Bye-bye.